Welcome back. Anybody have any questions about what you saw or heard yesterday as a place to start? Going once, going twice, hearing none. I'm going to talk about allergy this morning and allergic reactions. This is, let's see, I think I have to point it that way. It's 30 to 40% of what primary care people do every day. Now here's an interesting thing to me anyway. I know in February, the day that the maple sap starts running in the maple trees. There's a certain day when it starts to happen. I think it's when the daytime temperatures get above freezing, even though the nighttime temperatures are below freezing. But I know the day it happens, and it has nothing to do with what I might know about trees. It has to do with the day on which everybody starts coming in with runny noses and coughs and headaches. Because what happens when the sap starts running is the maple trees start putting out some substances into the air, and that triggers everybody's allergy. But it is a day, you go from one day where nobody's having that to the next day when everybody does. It's a pretty remarkable thing. So it turns out that allergy is a huge piece of what we do. And I want to sort of contrast that to what I said yesterday about bacteria and viruses, because a fair amount of what we do in the primary care world is try to differentiate what is caused by an allergy and what's caused by an infection. Allergy causes sniffles, coughs, wheezing, runny nose, postnasal drip, sore throat, headache, rash, low-grade fever, can cause diarrhea, fatigue, and congestion. I gotta point this thing down here. But it's also the actual cause of most arthritis, of type 1 diabetes, of rheumatic fever, which I talked about a little bit yesterday, of lupus, of thyroid disease, of inflammatory bowel disease like Crohn's disease, of multiple sclerosis, psoriasis, Guillain-Barré syndrome. Everybody know what Guillain-Barré is? Guillain-Barré is a reversible temporary progressive paralysis, where someone will start losing the ability to walk around, and a week to 2 to 3 weeks later they're on a ventilator, unable to move, and they stay that way for, depending on their own personal situations, they can stay that way for a week or two or a couple of months, and then they slowly begin to redevelop the ability to move around. So it is a very profound paralysis that is as a result of allergy. Poison ivy, in a certain way, is at least in part because of allergy as well. Let's see. But also, allergy also causes immediate hypersensitivity reactions like anaphylaxis, which, as you guys know better than anybody else, can quickly lead to shock and death. And that's the allergy that we have to balance off as we think about all the rest of it. So allergy really has 2 to 3 components. The body encounters a substance from outside the body. The immune system is triggered and the inflammatory process begins. And sometimes the inflammatory process, which is supposed to protect against and destroy viruses and bacteria, cross-reacts and actually starts attacking the human body itself, which is the source of a fair amount of problems. And when those attacks are sustained and directed against tissue, that's when we get things like arthritis and rheumatic fever and inflammatory bowel disease. So a good amount of what we see in medicine turns out to be allergy, not infection. And that's something that it took me a long time to figure out. Now, zillions of substances can trigger allergy. Pollens from ragweed, from grasses, from maple, oak, birch, and cedar, and any plants fertilized by insects. Cherry and apple trees, tomato plants, roses, and other flowering trees don't usually cause allergy, but things like cedar do. Anybody ever been to Austin, Texas? No? You guys are missing something good. So don't go to Austin in February. I went to Austin in February once, and within days, I was desperate. My eyes were red, my head was full, I couldn't breathe, and I couldn't figure out what the heck was going on. And then I talked to a friend who lives in Austin. He said, "Oh, you get cedar fever." And cedar fever is what happens in Austin when the cedar trees, which are apparently all over Austin, go into whatever their version of bloom is. So they started happening, and everybody gets sick. And what they're getting sick from is one massive allergy. The whole state of Texas comes down and starts coughing, and it's because of the cedar trees. Something we don't see in exactly the same way. There are a bunch of foods that can cause allergy. The classic ones are peanuts and shellfish. Those are the ones that cause the immediate hypersensitivity or anaphylactic reactions. Tree nuts, corn, eggs, meat, milk, soy, and wheat. And then, there are a zillion other substances like dust, insect sting, pet dander, drugs, latex, mold, cockroach and other insects, and particularly their scat, believe it or not. Soaps, laundry detergents, fabric softeners, plants, sunscreen, glues, nail polish, eyeliner, and nickel. Lots of people who wear nickel jewelry get little allergic skin reactions. Women who start having problems, women who wear eyeliner and start having problems with their eyes, it's often the eyeliner. Most of the rashes I see, or many of the rashes I see, turn out to be because of laundry detergent, and not so much laundry detergent, but even more than that, the fabric softener that's part of laundry detergent, which turns out to be super, really intensely allergic. And obviously, I live in fear of the allergies to medications. So, as you guys do, I ask every single patient who walks through the door, are you allergic to any medicines? Actually, the way I say it is, are you allergic to medicines or just doctors? Because I need to know on the front end if anybody's had an allergic reaction to something, and I need to know what the cross-reactivity is of one medicine to another. So some classes of medicines, if you take one, you're going to be allergic to another. The penicillins are like that. You need to know that the cephalosporins have a 10% cross-reactivity with penicillins. So if I'm allergic to penicillin and somebody wants to give me Keflex, there's a 10% chance I'm going to have an allergic reaction. And so I will, in somebody who's allergic to penicillin, avoid prescribing Keflex as well if I have another better alternative. So the immune system is a very complex process that has many different kinds of cells, T helper cells, T killer cells, leukocytes, macrophages, B cells. In medical school, they teach you all these things, and it's really hard to keep track of them, to be honest, and to keep them straight. And there are lots of different molecules involved in this, and different kinds of molecules, antibodies, antigens, something called complement and receptors. You can spend hours looking at the charts and graphs, and I decided to spare you guys that stuff because I'm not sure I think about it. It helps me think about anything other than, I just need to know that it's there. And the immune system involves lots of different types of defenses against infection. Each defense has its own battle rhythm with different timing and different associated symptoms. The immune system is designed to protect against viruses and bacteria, but as I said, is often fooled by substances that are chemically similar to parts of viruses and bacteria. So it gets triggered often, and sometimes too often, when no virus or bacteria is present. But if you want to think about it, the way to think about it is this is a system designed to be triggered in the presence of viruses and bacteria to get rid of them, but it gets fooled by other substances that look to the body similar. And that means that the symptoms of allergy are actually similar to the symptoms of bacterial and viral diseases. It's that similarity that gets everybody confused. So in terms of timing, the immune system has to encounter a foreign substance first and then react to the substance. And usually, most of us don't develop an allergic reaction at the first exposure. It actually requires a second exposure. So you can run into the most allergic thing in the world, that cedar that I talked about. If you've never seen cedar before, you're not going to react the first time. But the body, when it identifies the substance as foreign, then it kind of remembers the substance. I use the word remember in quote because it's a different kind of process, but it's a process that encodes it so that if the body encounters that substance again, it recognizes it. And then reactions we experience occur the second and subsequent times that the body encounters the substance. And those second and tertiary reactions, the second and third and fourth time, they can be pretty intense. So what happens immediately is that the immune system cells release chemicals, specific chemicals. And those chemicals do really three things quickly. First, they cause blood vessels to dilate. In most people, that allows other immune systems to find their way to the part of the body where the problem seems to be or where the allergen has shown up. But in some people, that massive dilatation of blood vessels is what you guys see as shock. So it's part of the same process. And then smooth muscle contracts. That's the kind of muscle that sits around the blood vessel, the bronchioles. And it's the kind of muscle that surrounds the intestines. So two things happen. The biggest one is people get bronchospasm and get short of breath. I get wheezing, and actually the other thing that sometimes happens is people get diarrhea or abdominal pain as a result. And the third thing that happens is white blood cells go from blood vessels into tissues searching for that foreign substance to destroy it. That's an approach that the body takes to getting rid of something it thinks is foreign and dangerous. And then there's a very complex interaction between all these different cells and substances that can last 96 hours. As the immune system tries to regulate itself, and that whole process varies tremendously from person to person. But as a result, people develop symptoms as a result of the substances that are released into the bloodstream. And those symptoms are the ones that include congestion, cough, runny nose, headache, fever, muscle aches, and sometimes abdominal pain and diarrhea. And after that, the body starts making antibodies and works on producing enough of those antibodies to identify, attack, and destroy all the foreign substances that are present. Usually, that takes 96 hours, but it can take as long as 8 or 9 days. And then once the substances are cleared, the immune response slowly powers down and the symptoms go away, if the offending substance has gone away. So if I'm walking around Austin and I get sick, I get all these symptoms because of the cedar fever, and I leave Austin, so I'm not around the cedar anymore, I'm going to get better 2 to 3 days later. But if I stay in Austin, as long as I'm in Austin and the cedar is there, as long as the cedar is in the air, I'm going to have a hard time. And that's what you see, here, because most of our allergies are seasonal. So, if there's plants out there making if there's ragweed out there and it's in making pollen, as long as the ragweed is there, I'm going to have a problem. As soon as the ragweed goes away, I'm going to get better. If there are things I can do to get the ragweed out of the air, I'm going to be a happier guy. And as soon as the foreign substance is reinduced, the immune system stays on and the symptoms continue, but sometimes the immune system becomes confused and keeps making antibody against a person's own tissues, and keeps making that antibody because the tissues are still present. That's what happens with arthritis or thyroiditis or diabetes type 1. In diabetes type 1, essentially, the immune system destroys the cells in the pancreas that make insulin. And that's why people have the problem that they have with basically no insulin. Anaphylaxis, or immediate hypersensitivity reaction, that's a life-threatening allergic reaction that presents with hives, with itching, with flushing, with swollen lips, face, and tongue, with shortness of breath, nasal congestion, stridor, wheezing, and cough, nausea, vomiting, diarrhea, abdominal pain, hypertension, tachycardia, syncope, incontinence, and dizziness. How often do you guys see anaphylaxis? Not too often? Anybody seen one that killed somebody? You are lucky.
Ryan, you want to give us an example?
I've been close.
I'm sorry?
I have an allergy to peanuts.
Okay, so
Nuts, and I've had a couple of bad anaphylaxis reactions.
can you talk about what it's like?
It starts in your chest. The two times that I've had it, I started in my chest and I started getting like cramps, where I would try to take a deep breath and then I would get like halfway to a breath and I wouldn't be able to breathe anymore. And then I felt it in my throat, I'd start getting real itchy, and then I could feel it in the back of my throat. I could really start feeling like, kind of like I was choking. Kind of the back of my throat started closing up. And then my tongue, it was at the point I couldn't keep it in my mouth. It was swelling so much. My eyes started watering. It was terrible.
So what do you do when that happens?
I took Benadryl right away that
Good.
time. And then I had to, actually, the most recent time I came to the station here and they had to give me Epi. And then I had to go to the hospital. I got Epi again at the hospital. And I was observed for 4 or 5 hours and sent home. I think I got more Benadryl at the hospital too.
I would imagine. How long ago was that?
Maybe a year.
Okay. So the immediate, taking Benadryl is the most important piece. Anybody know what epinephrine does in this setting? Why we use it?
Bronchodilator opens up the throat.
Well, it reverses some of the immediate effects, but it basically keeps you alive until the Benadryl kicks in. Benadryl, the time course of most medicines you take by mouth, it takes 20 to 40 to 50 minutes before those medicines find their way into the bloodstream and become active. And the idea is you got to stay alive until that happens. So again, the battle rhythm for anaphylaxis is, Epi first to keep somebody alive, Benadryl right after. You shouldn't do one without the other. And you probably you may often need a second dose of epinephrine. And then, we are now bringing everybody to the hospital because there's a late recurrence that sometimes happens a couple of hours later. So the idea is you bring everybody to the hospital. Often people will get IV fluid, and if you're in the field and you see this happen, having an IV in place is a good idea because you may find yourself needing to open up that fluid if somebody gets really shocky. But this kind of hypersensitivity reaction is never anything to play around with, because you can go from totally asymptomatic, shocky, and dead inside an hour. And peanut allergy is actually one of the ones that is the most significant. The second is usually shellfish allergy. These are relatively common hypersensitivity reactions. And I'm actually surprised that you guys haven't seen more of it because it's so common. And now often people will treat folks in the emergency department, but there's a bunch of emergency department docs who are admitting somebody to the hospital for 24 hours just to make sure they don't have the sort of late recurrence of going back into shock 4 to 6 hours later, which is possible. So, it's the thing that, it's the allergy thing that we live most in fear of. And as I said, it presents with, and you just heard the story, hives, itching, flushing, swollen face, lips and tongue, shortness of breath, nasal congestion, stridor, wheezing, cough, all that stuff. That stuff is something that, this is a real thing that happens not uncommonly, and it's something to pay attention to. Whoops. Hang on. Wait, I lost my place. Nope, I'm going back. Sorry about that. Okay. So like I said, it's always an emergency, always requires immediate treatment with epinephrine, always requires immediate transport to an emergency department, etc. Now, how primary care clinicians think about allergy. The first thing we do is look for evidence of infection we can treat. So when I have somebody who comes in with a sore throat or runny eyes or a cough, the first thing I'm going to do is look carefully in the ears to make sure that there's no ear infection if it's a kid. Make sure that there's no strep throat by looking at the throat, and listen pretty carefully to the lungs to make sure there's no pneumonia. Those are the distractors that the things that I can treat with antibiotics and often should treat with antibiotics. And then most of the time I don't find that. So most of the time I think then about how to treat the symptoms of allergy to make the person comfortable, usually until the allergic cause goes away. Now if it's a rash, I want to spend a lot of time going through things with the person to help them understand what they might be doing that makes them allergic. So I go through what detergents they use, whether they're using latex gloves or not, all the things that get that get on your skin that can cause allergy that people kind of run into in their daily life that they don't even think about. That is often the cause. And sometimes we do that when somebody's got the nasal and pharyngeal allergy symptoms, the coughs and the colds and the sneezes. We'll run through a run of treatment, and then if things don't get better, I pull people back and we think through what are the things in their environment that may be triggering the problem. And as I said, one of the things we do is try to steer people away from treatments that don't work. I can't tell you how many people every single day walk in and say, I got a cough, I need an antibiotic. And so a fair amount of my work ends up being talking people out of using antibiotics that won't help them. Anybody know why I want to do that most specifically? What's the big deal about using antibiotics?
It kills good antibodies, right?
I'm sorry?
It kills good antibodies?
Well, antibiotics actually kill good bacteria in the gut. So the intestines are filled with bacteria, and they do most of the work in digestion. And what you want to worry about is that when you use an antibiotic, sometimes you wipe out the good bacteria with the bad bacteria, and that makes people's lives miserable because it gives them diarrhea that won't go away. So getting rid of the good bacteria is one reason not to overuse antibiotics. Anybody know what another one is?
Resistance.
Exactly. Who said that? Good comment. So talk about it a little bit. Talk about antibiotic resistance. Can you? I'm sorry?
Like anything, it builds up resistance to it. Like tolerance for alcohol.
Well, it's a little different, but it's a basic idea. So the more we throw antibiotics around in front of bacteria, the more the damn bacteria figure out how not to be killed by the antibiotic. So they develop what's called resistance, and they actually, bacteria that today is killed by a certain antibiotic in 5 or 10 years isn't going to be, because as we use the antibiotic more and more, the bacteria evolve to get around the antibiotic. And so the more we use antibiotics and the more we use them unnecessarily, the shorter our antibiotics last. Most antibiotics last 10, 15 years, something like that. And then, everything becomes resistant to them, and they have to develop new ones. And that gets tougher and tougher as years go by. We have lots of challenges around resistance because, like large agricultural producers are using antibiotics all the time. They put antibiotics in animal feed in order to keep the animals from getting sick. And yes, it makes the cow today not get so sick, but what it does is over time it breeds resistance, and it might make the farmers work easier, but it makes the EMTs and doctors work harder as our antibiotics stop working. Anybody know what MRSA is? Methicillin-resistant Staph aureus. So Staph aureus is a pretty difficult bacteria that infects skin often, but can cause serious systemic infections and death. And once upon a time, staph was sensitive to most antibiotics. But as we used and overused antibiotics, the staph got resistant, and we bred a whole new strain of bacteria that we call MRSA, methicillin-resistant staph, that is actually relatively hard to treat. And so, we now struggle with people who, come in with multiple staph infections of the skin. And usually we can get in front of them, but sometimes we have to put people in the hospital. And one of the things that's difficult is when you get one of these resistant bacteria, if you can't get rid of it, we've had to close hospital wards and hospitals because we can't eliminate it from certain hospitals because the bug gets what's called virulent. The bug can be very invasive and can affect a lot of people, and we don't really have the antibiotics to get rid of them. So we end up doing things like environmental controls, being very hyper about washing down everything with bleach, which is part of the reason you guys go through the rigor that you bring to keeping the vehicles clean. But there are situations in which we really have been unable to control a bacteria and had to close units, and sometimes even hospitals. So, that's in a way wrapped around this whole allergy problem, because too many people in too many parts of the world use antibiotics for allergy. The damn antibiotics don't do anybody any good. So, like I said, we steer people away from using antibiotics, in particular they don't need, but people come up with all sorts of other crazy stuff. And then the other important battle rhythm of primary care is that we bring people back to make sure they're getting better. Nobody leaves, I don't walk out of an exam room ever without saying to a person, come back at this day or time, or, if this thing happens or doesn't happen, come back then. And that's an interesting difference between primary care and emergency department care. The emergency department, the expectation is that they're going to see somebody once and then move them to the primary care world. In the primary care world, our expectation is we'll see them once, we'll try something, but we know them over time. And so if something doesn't work, we can bring them back. Because the truth of the matter is the bulk of what makes people sick every day isn't going to kill them. And that means that having a relationship with somebody and giving them the opportunity to come back and telling them when and how to come back turns out to be really important for what we do and what we all do together. I mean, the thing that's kind of important for you guys is to understand that that's a fair amount of what we do and how we do it. To understand that we can bring people back and get things taken care of when they have to be taken care of. And good luck, guys. This is why we're videotaping this whole thing, so that people who have to get pulled out can look at the videotape later and see stuff that they missed if they want. Anyway, and the thing to remember about allergy is that most of the time, allergy is uncomfortable, but rarely life-threatening. So, in summary, allergy is common and a common cause of what people do seeking medical, or common cause of why people seek medical attention. The symptoms of allergy are caused by immune system and its function. Those symptoms are very much like the symptoms of viral and bacterial illnesses. Immediate hypersensitivity reactions are life-threatening but pretty rare but not unknown. And allergy also can cause severe chronic disease. Questions about allergy? About what we talked about so far? Who's got an allergy outside of that one? Anybody? Ragweed. And I bet it makes you miserable in August.
Did for a couple of years and then it stopped.
It actually tends to get better as people get older. Not that you're older.
Cured by now?
Anybody?
Shots
So
fired.
this is why I have no allergies. Anybody have family members with hypersensitivity reactions? That's pretty impressive. I'm sorry?
I think that was my first old joke.
You know?
Welcome to the club.
It's a sign of wisdom. All right. Well, in a couple of minutes, I'm going to introduce my colleague, Dr. Gutman, who's just arrived. Anybody, can we do another round of case presentations of you guys? No? You don't want to do that? Come on.
Every other day.
Just throw one at me. Anybody got one?
20-year-old complaining of a cough since the weather turned cool.
Hey, wait, that's cheating. Somebody throw one at me that of a run you've had recently.
That was probably one.
Anybody got another one? No? I'm sorry?
No, he's talking about like a case of an allergy.
Yeah, no, yeah, can somebody throw me one of an allergy case?
All right,
That's a
yeah.
good thing.
Allergy? No, I was gonna give you another one.
All right, go.
22-year-old female, syncopal episode found on the floor of her house. Alert and oriented when we arrive. She complains she doesn't remember the event. Her eyes went black. She passed out. Her brother found her. This happened 2 or 3 times a year ago after an abusive relationship with a boyfriend. And now it's happening again a year later.
Vital signs?
She gets up, walks, her eyes go black, and she has a syncopal episode. Alert and oriented, vitals are all stable.
Yeah, vital textbook. There's 120 over 80.
So,
Everything is.
right, so I'm gonna say if it's a syncopal episode, she needs to go to the ED, not to Blackstone, because it's not in our very specific list of inclusion criteria. So that's what I'm gonna say. What do you think might be going on?
Possible head injury, but why has it gone away for a year? And, she could be lying also.
Right? I mean, seizures,
Yeah.
conversion reactions. Sometimes people get overwhelming emotional outflows, and that turns into physical symptoms, so anything's possible. Anybody else? Another, what I'm trying to do is make sure that we practice the presentation stuff. So if those presentations are and stay sharp, that means the time elapsed on the phone is going to be shortest, and that's what I'm trying to get to. Really sharp. Go ahead.
Just a question. Are we going to be able to bring a patient after treating him with epinephrine anaphylaxis, we do epinephrine, are we gonna be able to bring it to this place?
Epinephrine and anaphylaxis and epinephrine, automatic ED. You know, I mean, that's anything that, you know, may have any life-threatening component to it. You don't have to think twice, you don't have to go, you don't have to call, you don't pay $200, you know, you just right away take them to the ED. Not even worth a phone call if you know that there's a life-threatening component to this. You know, the neighborhood health stations connection is for coughs and colds and sore throats and headaches, and in the beginning, for sure, that only. Because, you know, again, we never want to put anybody at any risk, and we don't want to make you guys have to make 2 trips. The art is to, you know, use the neighborhood health station if you can do it quick for somebody who didn't need the ED, but then to use the ED for every single person who does. And the other thing to remember is the person in charge of making that call is not the doctor or nurse practitioner on the other end of the line. The main person making that call is you, because you're on scene and you can see, hear, and feel things that nobody else can see, hear, and feel.
What about for the neighborhood health station, a mild allergic reaction, no epinephrine, a dose of IV Benadryl with no airway compromise?
I think an allergic reaction, give me a little bit more of the scenario.
So a mild allergic reaction, maybe to some type of shellfish allergy or something like that, doesn't require any epinephrine, just feeling a little bit of a scratchy throat and a mild rash.
That's actually ED because of the risk of late recurrence.
Okay.
You know, the problem with allergic reactions like that is the initial presentation, if there's a rash and what was the other, you know, a rash and a little bit of
Scratchy throat.
scratchy throat.
But it subsided by the time that we got there.
Once you get there, I think we're going to go ED, and then because of that late reaction possibility. Because what you don't want is for the person to be sitting, you know, in Blackstone at the neighborhood health station and watch them drop their blood pressure a little later. You know, the first dose of Benadryl will probably get you where you need, but you want ED observation for 4 to 6 hours to make sure that, you know, things stay the way we think they stay.
Would the time of day factor into what we bring to you? Because you're gonna be closed at a certain hour, so if it's late and they're gonna need observation, should we assume to go somewhere that's open 24 hours?
Yeah, if you know they're going to need observation. But the kinds of things that need observation shouldn't come to the neighborhood health station anyway. You know, the neighborhood health station is there for, you know, the immediate treatment of coughs and colds
So
and headaches.
drunks, you're not gonna be able to handle drunks.
That's right.
You need to open up another wing, because you're missing out on the good stuff.
Well, we've done a fair amount of work on people who are intoxicated.
You do a fair amount too. I
Well,
would
that's,
say,
we're
a
doing
lot
that
of
work
those.
because of what you're doing. We're watching those numbers. And one of the things that kind of got out of everybody's notice, the reason that got transferred to you, how did we handle people who were intoxicated 20 years ago? Anybody remember?
Throw them in a,
The drunk tank.
you know, drunk tank and watch them.
Not that I know. I'm just-
Yeah, but the drunk tank in the police department. And then somebody figured out that there's this 10% incidence of death for people who go into DTs. And, you know, the police department figured out there was liability, and so they said, we're not doing that anymore.
There's gotta be a better way than what we do.
We all think so. You know, there
So I wish somebody would come up with it.
well, we came up with it, and then they defunded it. You know, I don't know, and it didn't work as well as we wanted it to, but I don't know if you guys remember the Recovery Navigation Program.
Yeah.
You know, it was the beginning of how to do this,
Was that?
but then they
It's
closed
such a waste of resources. You know?
Everybody
It's-
thinks so.
There's
You know,
gotta
I
be a
mean,
better way.
well, that's, you know, they've opened this thing called BH Link in East Providence. I'm not sure we all understand how to use it yet. I'm hoping it will be as valuable to everybody as the Recovery Navigation Program was, but it is a real issue.
It is.
You know, and you know, it's probably a couple of transports a day for you guys, right?
5:35.
Yeah, I don't know what the figures out, it's all the time.
Yeah, and you know what happens to people in the hospital?
They get stuck in a hallway and, you know.
They
don't
get stuck in
really
a
get treatment.
they get stuck in a hallway till their blood alcohol level drops, and then they get put back on the street.
Right.
And we get no place, which is, you know, it's just consumes
We can
time.
solve that problem next after this, and then we'll work on global warming or something after that.
You know, if we can get this one and that one,
Yeah, that'd be good.
kind of that would be good. Go ahead.
Is that East Providence program, is that gonna be a transportable program, or is that just like a?
Jack?
Behavioral link program, there actually is an update that just came out with the protocol. If they are stable, we are allowed to transport there. I will be posting something on that this afternoon.
And the good news about that is, as I understand it, it's not just for intoxication and
Alcohol, drugs, and psych.
and psych. The big news is it's psych, and the psych thing is pretty important and pretty big. So that's a great question. That's been a hard thing for us to solve. All right, well, I'm going to step away. We're going to change some slides, so take 5 minutes. My colleague, let me now introduce my friend and colleague, Dr. Joshua Gutman. Dr. Gutman ran a practice in Attleboro for about 100,000 years. He's double boarded in family medicine and internal medicine. And now works for Blackstone some, and then travels the country visiting and working with community health centers and other organizations around the country, doing primary care and helping them figure out how to make sure things work correctly. He is a fount of experience and wisdom. He's going to take you through a couple of things and do some cases with you. And I gotta run to Boston, but I'll be back tomorrow morning at 8 o'clock. Thank you guys all. Take a break for till 10.
Thank you.